So good morning, everyone. This is another nice episode of Prostate Cancer Prostatic Disease podcast series. I'm here with Professor Dean Elterman, and we will go through a very interesting topic. I think, at least to me, it sounded like a futuristic topic. So I'll let you, Dean, introduce yourself and try to explain a little bit this new idea of first interventional treatment to the ones that are hearing us, which seems like a promising idea for the future.
Well, Ricardo, it's very nice to join Prostate Cancer Prostatic Disease podcast once again. And I'm excited to be able to discuss some new ideas, new concepts in what we're thinking about the treatment of BPH, particularly minimally invasive. As you know, I'm at the University of Toronto in Canada, and I spend a lot of time, of course, thinking about doing research, speaking about BPH LUTS, either with EAU or AUA or other associations. And so I think we're really going into a new time. And the new time is the development of all these new technologies. And we can kind of talk about those technologies later, but essentially, some time ago, I was speaking with Steve Kaplan, who is also one of the gurus, of course, of BPH LUTS in America. And we were talking about what are the gaps? We were talking about the current definitions of minimally invasive treatments. And the current MISTs like Resume and UroLift, iTind and Optilume BPH are excellent, and they really provide men a different opportunity to treat their LUTS different than surgery. But there's still another sort of sub area that needed to be filled in and to be developed, and that's where we came up with this idea of first line interventional therapy, or FIT, F-I-T. And that was really what we described in this paper that we put out in European Urology Focus, which is this concept of FIT, first-line interventional therapy.
So let me ask you something, because as a first interventional treatment, which is a very interesting idea, meaning to move a little bit surgery in the earlier stages of BPH for pathophysiology, but what do you think that the actual MIST are missing in terms of characteristics to become a real FIT?
So I think there's a couple things that differentiate MIST from FIT. So the current MISTs still require a level of anesthesia, right? And depending on where you work, you may have to give intravenous sedation. You may have to give a prostate block. Many places around the world are even doing general anesthesia, or even a MIST like UroLift or Resume, etc. And so the degree of perceived invasiveness, the degree of anesthesia is one consideration. The second is the need for the use of rigid instruments. A lot of these procedures, 3 out of 4, and generally 4 out of 4 that are available around the world, are still by and large, they have to be done with a rigid scope. And that is a hindrance. It gets in the way of patient comfort and the need for anesthesia as well. And next, it doesn't keep necessarily all the options open for future treatments. If you leave an implant in place, you might not be able to do other sorts of treatments, or at least it gets in the way. Patients are very concerned about the need for catheterization, right, post-procedure, and certainly the MISTs, for some extent, varying, do require post-procedure catheter. So there really is still some barriers, some obstacles, some special nuances around the MISTs, which are great, but they're not yet what we would consider to be a first-line treatment.
Okay, perfect. This is very interesting. I completely agree with you, all the way. So next important thing, because it's obviously we're talking about a futuristic concept, but where would you place the FIT in the timeline of BPH treatment landscape? What is your idea, or your and Kaplan idea? What's when we show these presentations, we show the evolving history of BPH, the natural history. So where would you imagine this? Like right after treatment, or just once you have a diagnosis of BPH?
So when we talk about first-line interventional therapy or FIT, what we're trying to do is create a new idea, a new concept that bridges the gap between medications and surgery. And you can actually lump in mist with surgery. And what FIT is trying to do is it's trying to be, of course, effective, minimally invasive with respect to relief of symptoms, minimal side effects, a fast, rapid recovery, and preserve treatment adaptability, meaning you can remove it, you can change it, you can do something else. So the ideal FIT, the ideal first-line interventional therapy will be outpatient. You're going to have to have some durability, but it really focuses on patient-centered outcomes. A lot of what patients care about is quality of life, return to work, return to activity, limited risk at the expense of durability, of course. And so what we're trying to do is shift the way that we intervene, not putting people on medication for many, many, many years, waiting for their disease to progress until they have to have an intervention, but maybe offering a first-line interventional therapy, a FIT, much earlier as perhaps even an alternative to medical therapy. Because it's really, all that's involved in performing a FIT is going to be a flexible cystoscopy, right? And we can talk about what are the new things coming out that might be characterized as FITs. But for many patients, they might just have a flexible cystoscopy, receive a first-line interventional therapy, and not even have to go on medication.
So here is a difficult one. I'm gonna go. Do you see any place for urodynamics this before FIT? What's your idea in the treatment pathway? Meaning, for the moment, the indications of urodynamics are very limited. Probably it depends. It's very controversial, actually, outside of the EAU guidelines indications, which are limited. So it's more depending on a urologist, actually, clinical practice. So do you see any place for that?
Well, that gets into sort of an interesting and, as you said, controversial topic as to which men with LUTS should get urodynamics. We have the upstream study, which identifies some factors. We have a number of papers that have recently come out looking at non-invasive or non-conventional urodynamic parameters, such as what would be a flow rate cutoff, what would be a PVR cutoff, which would indicate bladder outlet obstruction. You could extrapolate that. I have a feeling that a lot of these FITs, and we're talking about prostate stents and other novel treatments, will improve LUTS, diminish bladder outlet resistance, but not necessarily cure bladder outlet obstruction in those men who have high indices, high bladder outlet obstruction. And so I don't think FIT is going to be the cure for everyone. I want to be very clear. I'm not here to say it is just, though, a first-line treatment. Many men will benefit from it. They'll never have to go on medications and have the side effects of medications. But the whole point of FIT is that if it doesn't work, if it doesn't cure their bladder outlet obstruction, then it's easy to be removed and moved on to something more invasive.
Okay, that sounds nice. So the next subsequential question, how, because it's not very, let's say that I'm as into you in minimally invasive treatments, and something that it's really not there because there is no study with this endpoint is, how do you think an FIT or a MIST should be able to prevent BPH complications? Meaning, do you think that this is because you said, from what you said, it shouldn't be essential because it's a first-line treatment. But when we're talking about first interventional treatment, we're talking about something that may substitute medication. And so if we are changing like a FARI or FIT, do you think that it should somehow prevent, first of all, urinary retention, and should it prevent also, or actually more than prevent, to conserve the chooser function? What do you think about this? Because it's something that is not really there outside, so it's more like, what's your feeling? Because there's not much evidence outside.
Well, I think, when we look at studies of what men prioritize, again, they want to have preservation of sexual function. They do not want to become incontinent. They don't want to have long-term irreversible complications. And so we know that with medical therapy, there's a list of side effects that are possible. Most of them will resolve if you stop the medication. But by putting in one of these first-line interventional therapies, you're going to avoid all of those adverse events, all those side effects that we encounter with drugs. And because of the reversibility of a fit, if it's not fitting, so to speak, if it's not working for the patient, it can easily be removed and you move on to, say, a second-line treatment. So I think in terms of avoidance of complications, the whole point is that fits are easy to put in, flexible cystoscopy, easy to monitor in terms of how they are working, but of course they are easy to remove, they're reversible.
Okay, so you don't see a fit as something ablative. You see more like a something removable, or you see more possible removable, let's say, device. You see it more like that, so that you can manage actually to be more flexible, right? Is that right?
I think the first generation or the next generation of devices coming out that are going to be considered fits are all of these prostate stents. There are 5 different prostate stents that at least I've been an investigator for that are going to be coming to the market in the next little while. And they are all temporary. They're all stents that can be put in and ultimately left in as long as necessary and removed. There will, on the horizon, be ablative fits. They're not yet really released yet, but there will be an example of these treatments that will go into ablate tissue for sure, but that's still to come.
Okay, so now I have another question which is a little different, which raised while reading your excellent manuscript. And what do you think, do you think that the introduction of FIT into the treatment pathway of BPH will create some disparities or enhance the already present disparities in terms of access to treatment in BPH? Because there are several manuscripts which actually analyze, and they see that minorities may not be able to access or a missed pathway, or may have less access to surgical treatment, or are less adherent to medical treatment. So how do you see this? What do you think that it would be too expensive for everyone, or how do you see this, or do you think it will be cost efficacy? Because as you say, if it's an FIT could reduce the pharmacological expenses. It's always very difficult to analyze the cost effective of benign diseases, but what are your thoughts about this?
I think there's a number of ways to look at it. Number one, we know that on a day-to-day basis, BPH medications may not seem very expensive. But if you take that out over the course of decades and a lifetime, BPH medications do have a significant cost. Additionally, when you do cost utility Markov models, the adverse events of medical therapy also have a cost, quote unquote. They may not necessarily be a dollar cost, but they are a cost to the person who's experiencing adverse events from medications. On the other hand, the minimally invasive therapies that are currently available are very expensive. And so I would envision that these new fits, I hope, will be less expensive in some respect to the currently available mists. They're going to be given in a regular outpatient setting. So we're already doing diagnostic cystoscopies on so many patients. So the idea is that a fit goes right into the process of the diagnostic cystoscopy. You could envision someone coming in for an assessment, they do a flow, they do a PVR, they get a flexible scope. And while the scope is there, you say, you know what, you have obstruction, would you like me to put in a fit, as opposed to would you like me to write you a prescription? You can have the conversation beforehand. Now, I think we're never going to be able to replace all drugs for BPH around the world. There's just too many tens of millions of men suffering from BPH LUTS, hundreds of millions. But I do see us trying to lessen the burden of disease, give patients options, and I hope it isn't necessarily just for those who can afford it. It will, I hope, propagate over time. But there's just not enough urologists around the world to treat every man with BPH LUTS as well.
Well, I completely agree with you. I like this new idea. What I should, if I can, I should underline that for people who are hearing us, probably who are not probably managing mist every day as we do, actually flexible cystoscopy is becoming actually a main diagnostical procedure before surgical management of BPH. So especially for the young residents, which will find strange to do a flexible cystoscopy, it becomes very important before treating someone with a mist, because most of the mist obviously don't apply that you really need before implanting or before treating the patient. You need important information, even if we are not able to classify obstruction. What we are able to do is to see if there is a high bladder neck, if there is a third lobe, which is something new actually. If you think 5 years ago, we wouldn't be imagining actually to do flexible cystoscopy, and I like very much this concept of actual delivering the FIT in a outpatient setting, a flexible cystoscopy. This seems well, a little futuristic, but probably it seems doable. It doesn't seem that far. Let me use the word. So the last thing I want to tell you, what should we actually do as a researchers? What are we? Should we just wait for these new devices to come up, or do you think that there is something more to analyze before reaching the ideal FIT? What should researchers focus on?
Well, I think first-line interventional therapy is a concept, right? It's a new way of thinking about intervening earlier as an alternative to medical therapy in an outpatient setting with some sort of intervention. And we still don't know what is the perfect fit. There's more devices that are going to come out. Of course, every product that comes to market isn't always going to succeed. And from a research perspective, I think we need to continue to come up with ideas, both in terms of developing new devices, new concepts to treat BPH LUTS in this fit paradigm. But also, as they come out, we're going to have to assess them very critically. We're going to have to see whether they work, whether they have issues of comfort, compatibility with the patient, migration, increasing storage LUTS, whether they improve or don't improve bladder outlet obstruction. And of course, first and foremost, like with all BPH, you have to find the right patient for the right treatment. And I can tell you, based on some of the preliminary research that we've done, not every person, not every prostate will be suitable for a mist, and not every person in prostate will be suitable for a fit. And what we need to do is be able to identify those prognostic factors: intravesical prostatic protrusion, median lobe, prostatic length, presence of detrusor overactivity, instability. Whatever it is, we're going to need to start to do a really good job identifying those patients who should get and who should not get a fit or a mist.
You know, this is a very important concept in my opinion. You know, it's been some years that we've been in the BPH scenario, and what is very intriguing and interesting is that even though we're talking about BPH, we've been talking for several decades, we still don't have like the ideal outcome. You know, that when you go through the literature, every paper decides which is their outcome, their primary outcome, if ejaculatory function, if flow, if IPSS. And I think what you said, you know, sometimes it should be the ideal for, especially now in this new patient-centered model, It's just to see how happy is the patient before and after the procedure, because that's the point. I mean, we're talking about, benign disease. We're talking about patients which have bothersome LUTS. And so probably, especially when looking at the literature on MIST, I think that we really should focus on patient-reported outcomes. And probably we're shifting, and what you said, what is very interesting, which is present actually in the BPH6 study, is the fact that you need to have the return to normal activities score. This is very important. I mean, you go, as you said, if you go for a flexible cystoscopy, you're at work next day. So we need something for people, especially young people, to be able to manage. You cannot be out of work for a month. It's invalidating to be out of, and probably it's missing from the actual MIST. Some of them have a very quick recovery, but some of them may take even more than 2 weeks for the recovery. So it's difficult to talk about minimally invasive if you still have to be actually out of normal activities for a couple of weeks. So I think it's a very interesting landscape, and I think that what it's nice about your recent paper and why I wanted to do this podcast is because I think that for young people, it's important to open the mind to a new way of treating BPH. And the other thing is that it will take much longer to do BPH consultations. Before we may, okay, you have some LUTS, okay, this is the alpha blockers. Now we have to go deep inside into the whole social context of the patient. It's not the same to have a taxi driver or to have someone who works just homework, so smart working. So I think it's just changing. So I give you the last words to conclude, and I think that we've gone through all the important aspects of this topic. So please conclude the podcast.
Well, I think, Ricardo, we leave on a really interesting idea. And this has become, I think, probably the hottest topic in medicine and surgery. And it's this idea of shared decision-making. Shared decision-making is about sitting down with the patient, and what the physician brings is their experience and expertise, the knowledge that we have from the clinical evidence from published publications, and all of that is balanced against the patient's preferences, their values, and their desires. This is what shared decision-making is. It isn't just listening and doing whatever the patient wants. And it's not what the patient listens to what the doctor wants. It has to be a two-way dialogue. And so as we introduce new concepts, new treatment paradigms like MIST, like FIT, the idea is that we're able to meet the expectations, the demands, the values, the preferences of our patients. If we only have one surgery available to us, we will not be able to meet the expectations and the preferences and the values of all of our patients. They'll be disappointed. And so the idea is, as we introduce something like first-line interventional therapy, there may be many men who would prefer to preserve sexual function, to have a minimally invasive treatment, who would like to have something reversible, who would like it done as an outpatient with a flexible scope. And so as we get deeper into this idea of shared decision-making and having input from patients, we need to have tools, we need to have options to give them. And I hope that first-line interventional therapy, FIT, continues to allow us to evolve our concept of what BPH LUTS treatments are. And then we can challenge the inventors to come up with new and brighter ideas, and ultimately meet the demands of our patients to make them happier and improve their quality of life.
Okay, thank you very much, Dean. So this was another very interesting episode of Prostate Cancer and Prostatic Diseases podcast series. So please follow us on X, on YouTube, and on our new Spotify channel, so that you can enjoy our podcast during your travel cars. Okay, so thank you very much.